Ms. Green-Harris is the director of the newly created Center for Community Engagement and Health Partnerships in Milwaukee, which works to advance research in the African American community in a culturally inclusive manner. She is also the director of the Milwaukee Regional Office of the Wisconsin Alzheimer's Institute, where she oversees the health equity pillar for that group. Is also the director of the Lifecourse Initiative for Healthy Families, a community-driven initiative funded by the Wisconsin Partnership Program, which develops and implements strategies to reduce disparities in birth outcomes for African Americans in Wisconsin. I know there's some staff from the Life Collaboratives in the room today. I'd like to recognize Pamela Smith, who's here today. Thank you for joining us. I'm extremely excited to have Ms. Green-Harris here today, so take it away.
Thank you. Good morning, everyone. Okay, let's work on this. Let's work on this. It's almost noon. You guys have had plenty of coffee. So good morning. And I want to thank you for this opportunity to actually talk a little bit about what the work is that we're doing on the other half of health and the social determinants of health. So I always start out my presentations by letting you know that there is science in the slides, but it's really the heart of the passion, and that our jobs really focus on making sure that the people in the communities are reflective of the work that needs to be accomplished. So you will see some stats and you will see some data, but the majority of my conversation for the next 20 minutes or shorter or so, we'll be talking about how programs are essential to discussing these issues around dementia and, quite frankly, infant mortality, which we know, in all honesty, will not be resolved in the next 2 to 3, 10 years. But we do know we can begin to start having programs that are affecting change over incremental time, and that's what I'm going to talk about today. So I want to put you in the context and the framework of understanding, and this will come from a lens that is relative to the communities we serve. So our populations primarily focused in the African American community, so the social determinants of health are absolutely relative to the conversation. And so I do want to thank my colleague here for such a great platform and presentation, and of course Representative for setting the platform for what we're doing and what we're discussing today. The work that you're doing with the kids and the families is absolutely wonderful on both fronts. And so you've answered a lot of my slides, so I'll skip through some of them. Is that all right with everybody? Yeah, say amen. I mean, say yes. It's all good. And so I'm going to get started. Basically, what we see here in this first slide is that social determinants, basically, as we've already talked about, are essential and really do matter to our health. And this one actually talks a little bit about education, as my colleague has just discussed. Education is critical to us addressing the issues around infant mortality, around Alzheimer's disease, because we know that what we do at the beginning of life actually impacts the end of life. There's not a way where we can actually just talk about if we have healthy babies that we can ignore the end of life trajectory. It doesn't work that way. It's all about life course. And what we do at the onset will significantly impact the outcomes, and that's exactly what I'm going to share with you today. The other thing we also know is that with better education, we also have higher economic attainment, along with better housing, stability, and again, we will show you later in stats how this actually will increase our brain health. Is what research is showing. So obviously, mom's education increases a baby's chance of survival. And then I want to go and just talk about adverse birth outcomes in African American women. Obviously, there's a social context behind that. But the other piece about that is that when we look at African Americans having the highest rate of mortality and adverse birth outcomes among all ethnic and racial groups, that's really critical, because while I'm telling you education is important, I also wanted to let you know, for those of you who don't know, and I know there's many folks who already are doing the data collection around this, education alone is not something that we can depend upon. It's all of the social determinants, because even as an African American woman with a post-education, I still have higher risk for infant mortality or loss of a child. So it's not just entangled in the let's get a better education system. That's just one of the pieces of the pie. And so that's why we have to talk about the data is very critical to the work we do, but equally as important is what do we do for those social constructs to begin to address this issue from the social determinants and the social side of health. Does that make sense, everybody? Mm-hmm. So And by the way, I just have to put the disclaimer: 20 minutes is like 5 minutes to me. So you just have to work with it, sister. Uh, but I want to be clear when we talk about here the racial disparities. What I want to emphasize here is lifelong stress. This is going to talk to you about why is stress important. Lifelong stress. That fourth bullet up there says stress and racism are constant factors in African American women's lives and are inseparable from our pregnancy or their pregnancy experiences. So again, beyond education, we have to understand that stress across our lifespan does actually impact our health and our birth outcomes as well. And again, I'll show you in the same with dementia as we get to that slide. So basically, I want to talk a little bit about the LifeCourse Initiative. The LifeCourse Initiative for Healthy Families is a regional collaborative effort to support African American women and their families to have healthy birth outcomes. It was initiated in 2009 under the Wisconsin Partnerships, and the goal is to address issues on big or small P policy, systems, environmental changes to address the root causes of why these disparities exist. And that has been interesting, and we have actually understood, if you look at the chart that we're showing, counseling and education, when you look at it, has probably the smallest impact but you have to go down to those socioeconomic factors, which again, we look at oftentimes clinical reasons why women are having birth disparities, or we start talking once a woman is pregnant. We have to go back and actually look at all of those risk factors, those socioeconomic factors from the very beginning of that life course, not just at the point where a woman is actually becoming pregnant. So it's a Wisconsin issue. We know that Wisconsin has one of the worst black-white disparities in infant mortalities in the United States. We're working towards making sure that that is not the case, but it is right now, and most of you know that in this room. And we also know the Life Course was initiated to address the disparities that is among African American women. Clearly, the chart shows that there is a racial issue in this state. The total, of course, ratio of infant mortality is 5.9 overall, but 13.9% of African Americans experience disparate birth outcomes. So what is our approach? Basically, infant and child well-being is a reflection of access to health care and health information, as well as social, economic, and physical environment. So we know that basically we have to address the issue. Again, improving health is more than just looking at health systems. It is actually addressing the individual needs, but also the systemic drivers and forces behind why poor health is actually occurring in our community. So we talked about the LifeCourse approach, and I'm going to talk about it real briefly for you. Again, these are regional efforts that we're going to do, but we're also doing the efforts at a grassroots level. I want to talk real briefly that the LifeCourse approach talks about using community. It talks about relationships, building the strength and the assets of the community, and then it talks about looking at what policy systems and environmental changes do we need to take. We know it's a local issue, but most of these, if you can probably see neighborhood conditions, discrimination, unemployment, and on and so forth, basically are in individual communities, but we know they mainstream across several segments of all populations and all of the neighborhoods that we're actually looking at. For healthy babies to be born and stay healthy, we have to focus on the moms, the families, and we have to have access to quality health care. Social and economic environments actually promote positive health outcomes for these moms, babies, and families. And so our local efforts, basically we have life collaboratives. We have a collaborative model that we are actually putting into place. It's a coalition action theory and collaborative action theory that we're putting into place. And we have identified currently 3 communities, and they are Racine, Kenosha, and of course Milwaukee. And the goal, of course, is to engage diverse stakeholders and groups in developing and implementing multi-level solutions to dealing with this issue. And Life Collaborative members include residents, leadership from nonprofit healthcare, business, public sector, and faith organizations. Again, going across systems so that we can actually address this issue in a collective manner. So what are the local efforts? And as Sam has indicated, Pam is here from Ms. Pam Smith from the Kenosha Collaborative. Each of the collaboratives has an action agenda of local policy systems and environmental changes and policies. And why is that important that each community has their own? It's relative because while we can talk about the systemic issues that cross unilaterally across all communities, there are some unique differences and there are some clear-cut priorities for each community. So what you'll see is that Kenosha focuses on mental health and housing. Milwaukee Life Collaborative focuses on reducing prematurity, and the Racine Collaborative works on breastfeeding and teen health. Now, we also know that because we have these issues at the local level, it doesn't disconnect us from what's happening regionally. And so we know there are some common threads across what happens regionally. And quite frankly, more than 80% of the babies born to African Americans are in Kenosha, Milwaukee, and Racine counties. And because we have the worst disparity in the country, we know that we have to connect and see what can we do to actually garner the reduction in these communities together. And so what we have actually created is an opportunity for us to come together in a regional work group setting that crosses all of the continuums of the community to have a common mission as well. It is our goal not to just, again, it is our goal to reduce the disparities locally, but regionally and statewide. And the only way to do that is to come together. So we have a universal depression screening for African American during perinatal period. We know that, again, depression reigns in the community. We understand that it's still some stigma related to that, but we want to begin to address that. So over the past year, as a regional working group, we've worked together to identify this regional priority. The members have developed a working understanding of this priority. And we're setting to actually develop some specific outcomes for 2019. Our strategies need to be within a scope that we can, that's either existing or something that we can actually secure so that we can make sure we're actually affecting the policy systems and environmental change. We also know that the priorities, by the way, were actually identified by the collaboratives based on what we have come together using data to support where we're going in this initiative. We also have, by the framework we're going to use is to lead or co-create a stigma reduction campaign around depression that we know is facing our community. We're going to support to co-create provider education about stigma and then monitor. We'll advocate for quality improvement project to increase maternal depression and screening and address the barriers that women are actually acknowledging to actually getting screened, but also to address the barriers that providers are suggesting around screening themselves. And so we're really trying to make this an effort that addresses all of the stakeholders so that we're not just doing one piece of the pie and not serving the whole dish. The question for the collaboratives are there concerns about adapting an action agenda, and how do we do that? And we're going to focus on that. While I talk about the differences in community, and my colleague here, thank you so much, Lenny, for talking about fathers. One of the common themes that we've come across, and so I talked to you about the initiatives at the local level, right? Each of them have different focuses, but we know it's not, we can't just focus on moms and babies. We've got to be inclusive of the entire family. And I'm really proud of the initiatives that have come out of each of the collaboratives. And one common thread across that initiative is the inclusion of fathers. Fathers play a very integral role in our children's lives. And so in Milwaukee, we have a barbershop sessions to elevate dialogue. Kenosha developed a fatherhood program that adds involved fathers through the WIC program. And then Racine focuses on building capacity to support breastfeeding for moms through fathers, which is also, all of these initiatives are designed specifically to engage the father in parental activities, along with making sure that the community sees the dad's involvement as critical to how we move these agendas on addressing these disparities. And so some of the opportunities that we believe are, obviously, again, we've addressed those, so I won't hound on them, but basically advocating for policies to improve the overall social and economic health and well-being of the population across the lifespan. That includes poverty reduction, earned income tax credit, right? Housing. We would love to see something that addresses the issue around eviction of pregnant moms, so that when a mom is pregnant, we make sure that they have stable residence. We just talked about the issue of stability. We know that has to be important. Also, another critical piece is improving access to quality care. Just as we've talked about depression as something that we want to address, we also need to make sure that there are actually competent providers who can address the issues that these moms are facing, along with addressing the issue of stigma that is a huge factor in why some moms would never even talk about depression, and or poor treatment once we do enter into systems. So we really need to address some of the systemic challenges that we're facing, along with other issues such as childcare, work support, and of course our favorite, paid time off for moms. So I'm going to briefly, in my next, I think I got about 7 minutes, talk a little bit about Alzheimer's disease. And I will tie these two together so that we can understand from the beginning of life perspective to the end. So Alzheimer's disease, we know that in this country, Alzheimer's disease is the 6th leading cause of death in the United States. We also know that every 66 seconds someone is developing this disease, and we also know that baby boomers continue to age, and these numbers will not go down. The yearly out-of-pocket costs for services and programs can range anywhere from $3,500 to $20,000. That is really relative when we're talking again about healthcare, when we're talking about systems, structures, and support for what happens with this dreadful disease. Now, the other key factor we need to understand is that it's going to cost us $200 billion in healthcare to continue to care for families with Alzheimer's disease. So we have to come up with creative solutions. And I want to do here a commercial break to stop and thank the Wisconsin legislators who have put forth the bill to start addressing Alzheimer's disease recent as October 20th, 2017. We are looking forward to legislators, and we certainly have been doing our calls to make sure that we support that, because we know family caregivers are definitely in need of more supportive services, and we also know we need to address some of the systemic challenges for families facing Alzheimer's right now. So African Americans tend to be at greater risk for Alzheimer's disease, as with other social determinants of health. And we'll talk a little bit about that. Basically, roughly double African Americans are more likely to get some form of dementia in a lifetime. Now, the key factor here is that we know it's not necessarily genetic, so it has to do with some of these social determinants that we're talking about. And even as the research shows, basically what we are finding is that when we're looking at what will help folks of color, it's basically coming out to be some of the social constructs that we know we're facing. So we try to address this issue with our programs and services, and we initially thought the challenge was that folks just couldn't access care. So we created a model of a memory clinic, a diagnostic memory clinic in Milwaukee that focused specifically on African Americans at Milwaukee Health Services. This was funded through the Wisconsin Partnership, which we were excited about. The goal was to get folks to the clinic to get a diagnosis, because when we did our research in the community said to us, "You guys are so smart. You can tell us we have Alzheimer's disease, but how do we get a diagnosis?" And so we went out and helped develop this diagnostic clinic. And what we did is we did something a little unique. And we actually put the patient at the center of the care. We worked with them to get a diagnosis from a provider, but we didn't stop there. We actually went back to provide care support, not only to the person living with the disease, but that care provider. We connected them with services such as the Alzheimer's Association, Interfaith for older adults, so they could get respite care. We connected them with the Aging Disability Resource Center so that they would then have services that could connect them to care. And we began to basically get an understanding that this was important. The first step was to get a diagnosis. The second step was to actually educate providers on how to diagnose. What we do know, according to the Alzheimer's Association, is that only 41% of the doctors are providing diagnoses for their patients who they know have Alzheimer's disease. And that's critical, because what we also understand is that people want to know if they have dementia. Why? So we can plan. Why? So our families can actually understand what this caregiver journey will look like. There's been a recent work by Dr. Amy Kine at the UW. We had to go further. The socioeconomic contextual understanding of disadvantaged neighborhoods. Again, back to what we've all been talking about. The fact of the matter is that we can get a clinical diagnosis of dementia, we can provide social support, or we can provide services, but the fact of the matter is that we know that neighborhood disadvantage early in life is going to play a role in those outcomes. And so this is an early study, but we have found, and what is being found is that disproportionately higher levels of low socioeconomic status and disadvantaged neighborhoods leads to higher proponents of folks getting Alzheimer's disease. Now, that's critical and crucial because what do we do in this context and how do we actually address these issues in the community? Because we also know the other report says stress is significant to these communities. Again, many of our research studies focus on genetic testing. And what are the genes showing us? The fact of the matter, in African American communities and other communities of color, our Hispanic neighbors, along with our natives, we're finding it to be more social constructs, more so than it is necessarily only our genetic makeups, which is going to be crucial to what we know we have to do. So I just wanted to give you guys again for the risk factors, and for those of you who wanted to see it in black and white, African Americans basically, and these are RAP participants, Wisconsin Registry for Alzheimer's Prevention, demonstrate higher blood pressure, diabetes, and obesity than our white counterparts, hands down. Again, social determinants of health is clearly in here. So what is the burden of Alzheimer's disease in communities of color? Let me talk briefly, and then I'm going to come to my conclusion. More likely than not, African American caregivers will provide more hours of care, higher intensity of care, and use less access to supportive services and to not access services. We also know that the bottom bullet says even though African American caregivers are caring for severe elders, basically they are less likely to place them in nursing homes, which means, again, the high level of caregiver burden and stress. And we also know that while we're caregiving for our loved one with this critical illness, we also are caregiving for other people in addition to this frail elder. We have minors, grandchildren, and other family members. We also know that our children, our caregivers, are more likely to be African American women of working age, 44 to 65, unmarried with less formal education, fewer financial resources. The data also shows, again, less likely that we will be able to sustain our income over time. There's more loss in these communities. So, but the good news is that caregivers of African American communities find it rewarding to give care, more so than our white counterparts. And that is, reasons include basically normative of the experience, right? So it's my duty to caregive, right? It is something that gives me actual purpose. And then our spiritual guidance also plays a role in why we have much more rewarding experiences in caregiving. However, I want to give the clear message that it does not negate that we actually experience worse health outcomes, even though we have greater knowledge in saying that we are experiencing a better caregiving process. So what have we done? We've actually tried to listen to the caregivers, and the caregivers have said, again, we understand we have to be on this journey. We looked at Dr. Mary Middleman's work. She actually invited us to come to New York. She had a course that provided positive experience for caregivers. It started out as a respite program for caregivers who were caring for folks with Alzheimer's disease. One of the stats I did not share is that caregivers actually who care for people with Alzheimer's disease tend to have less poor health than those of just other types of health care. So our caregivers asked us for programs that could support families. So we have what we call the Amazing Grace Chorus Family Support Program. It's culturally tailored, based on evidence. It is stigma reduction. It gives caregiver support, educational presentations and resources. We bring the resources to the family, but we also provide social support and peer learning for the family members or the caring parents, as well as those who are experiencing the disease, along with the caregiver and extended families. Now, one of the biggest and best parts about this mission is that it's no cost to the family, and it's 14 weeks of performance. that you will get to see. The one thing the caregivers, and I'm going to let you go, Sam, in 2 seconds. Sam's going to share something briefly, but I just want to say this. What the caregivers and what the folks who experience this course have said, it reduces their caregiver stress. It improves the mood of both the caregiver and the person living with. It improves memory recall, self-confidence, and the like. So we have just a snippet of what the course
This was
has
working at
done.
9:45 this morning, so cross your fingers, everybody.
So it's good to see everybody here today. I hope you've had a wonderful, wonderful, wonderful week.
One of the things we know is that when we bring programs into communities of colors, it's very important that the community actually lead the program, if you will.
We're gonna do the vocal warm-up.
We wanted to bring them into an experience where they could actually enjoy the process and learn from the process and help us understand if this is actually the way to go.
The first session we had was interesting. A woman, she stood up and said, "It's about time somebody's doing something for us." That says a lot.
As the folks sing, we see them light up. We see them actually engage. And we hear stories from the caregivers saying, "My mom is singing at home. My dad is doing new words."
I see self-confidence in many of them from when we first started. What I'm hearing from the caregivers with their loved ones, they see how they're more verbal. They see them singing the songs at home. Other caregivers feel the support.
The thought of the choir was first presented to us, I really kind of hesitated, but certainly I am super glad that we were willing to step out and try it, and then it's become way more than I would have thought. I think it's helping her with her memory, and that, of course, makes us feel good.
It brings back to memory things that occurred in my life a long time ago, and I have a lot of fun with it with my children.
It lifts the spirit, and I'm so glad that it helps my wife a lot. She can be pretty down when we leave the house, but when we get here and start singing, and especially if I lead a song, she joins in and helps me without even being asked, you know. So it's very helpful.
I feel free when I sing. I feel happy.
Singing it and then listening to others sing in the group is uplifting. We can't wait to get here for practice, and when we leave, we are feeling good. You know, it keeps us going all during the week.
And after you've been here for a while, you actually feel the therapy and you feel the remembrance coming back. You know, it helps you with your mind, body, and soul. It really do.
It's a family thing, you know, and they look forward to coming now. It's rain, sleet, or snow. And some of them come aching, but when they come here, it seems like the aches and the pains all go away.
So we know that providing support to our families is critical to the work that we do, and we are honored to actually do this work. I'm going to end with just 2 thoughts. Common threads, again, LifeCourse Initiative, LifeCourse as a whole. We know the common threads are lower income. We know adverse health outcomes, disadvantaged neighborhoods, but we also know lack of access, but we know there are also modifiable risk factors and programs that we can do to actually integrate ourselves so that we can build programs like this so that our families, while we may not be able to cure Alzheimer's disease, while we may not be able to end the adverse birth outcomes tomorrow, we can do things intermediately to make sure we're addressing these issues. So I want to thank you and for allowing me to have this presence in this moment, and I will answer any questions. Thank you.